All right. So in the interest of time, I don't want to take up your time too much today. So I'll keep doing my best to get people into the session from the waiting room here. But in the meantime, hello and welcome everybody. This is CEPA's student webinar entitled, "What Does a Clinical Exercise Physiologist Do?" My name is Dr. Trent Hargens, and I will be your host today. I'm currently an associate professor of kinesiology at James Madison University in Harrisonburg, Virginia, where I teach in the undergraduate exercise science program, as well as our master's program in exercise physiology. I currently teach all of the clinical exercise physiology related courses within our grad program. I am the immediate past president of CEPA, as well as the current chair of the Continuing Education Committee. I'm very excited to see so many students registered and here today for this informative webinar. And now I speak for those of you who couldn't make it live and are watching this recording afterwards. I offer you welcome as well, and be sure to email CEPA with any questions you might have for our experts. We can make sure that your questions get answered as well. The purpose of today's webinar is to hopefully give you students some insight into the field of clinical exercise physiology. Some of us work in different settings, the different settings that clinical exercise physiologists typically work in, the type of work that is done, as well as the many benefits CEPs provide to their patients. I myself was a practicing CEP for many years prior to my turn into academia. For this webinar, however, we sought to tap into the expertise of some of CEPA's excellent member practitioners, those who currently are out there practicing, and allow them to provide the next generation of potential CEPs more information on the field. Some of you in this webinar may already be CEPA members. Many of you are not. I would ask that you take a minute to consider joining CEPA as a student member. CEPA's purpose is to advocate for the profession of clinical exercise physiologists. CEPA is a affiliate society of ACSM in that we are autonomous, but receive ACSM staff and logistical support as a smaller organization. We are compared to ACSM. We provide continuing education opportunities for members, career development, and networking. As younger CEPA members, students can benefit greatly from the networking that being a member can provide. We have recently ramped up our job sharing on our website, meaning career opportunities in the field are beginning to flow through our website and our social media outlets. Finding jobs is, of course, always a good thing. We also have, as part of our CEPA leadership structure, a student affairs committee. Their purpose is to propose and advance organizational initiatives for our student members. You can become involved in that committee if interested. The cost is only $15 for students to become members. And as a student member, you would gain access to all of the member benefits, including in these benefits are access to the Journal of Clinical Exercise Physiology, which is the official journal of CEPA. Additionally, you would have access to member resources like the CEPA internship directory, if you were looking for an internship in the field. If you're interested in learning more about membership, I'll be putting the CEPA website URL in the chat shortly. A couple of housekeeping items before we begin with our first speaker. Please keep your microphone muted and your video off as our experts speak. There will be some time after each speaker for some questions. Given the large number of attendees here, I would ask that if you have a question for the speaker, please type your name in the chat box on a private message to me, Trent Hargens. I will field those questions in order of the speaker. If we don't get to your question before we move to the next speaker, there will be some time at the end for questions for all of our speakers, and I will do my best to get your question into that queue. Now, without any more of me talking, let's get to our first expert and our first speaker. Matt Thomas is the director of the Cardiopulmonary Rehabilitation Program at CHI Memorial in Chattanooga, Tennessee. Matt has a BS in kinesiology from Manchester University, an MS in clinical exercise physiology from Ball State University, just like myself, chirp, chirp, and an MBA in business administration from Indiana Wesleyan University. Today, he will be discussing the area of cardiopulmonary rehabilitation. Take it away, Matt.
All right. Well, first of all, very impressed by the number of people that are in attendance today. This is really encouraging. When Trent asked me to be part of this talk and I saw the topic, immediately I thought, wow, this is the talk that I wish I would have been able to hear about 12 years ago, because I really didn't know a lot about what CEPs, who they were or what they're doing. And to speak a little bit of why I feel like I'm qualified to answer the title question for this talk, it is the exact thing that my grandparents and my parents have been asking me every week for as long as I have been employed in the hospital setting. So clinical exercise physiologists. Who are they? What do they do? Well, my portion of the talk is really going to be focused on what we would kind of consider to be more of the traditional setting where EPs find themselves working, and that's cardiopulmonary rehab. So this is inclusive of cardiac, of pulmonary, and most recently, vascular rehabilitations. So I thought that first, before I got too deep into what the exact roles of our CEPs in this setting were, it would be very important and apropos for us to talk a little bit about what cardiopulmonary rehab services are, just to set the stage a little bit, because I think this will carry through a little bit to some of the other presenters. So cardiopulmonary rehab is a medically supervised exercise program. Now, important to point out that it is not exercise alone. It is a multidisciplinary approach to care. And for lack of a better term, it's something that we call secondary prevention programs. So in short, individuals who have chronic disease, clinical illness, secondary to that diagnosis, they find themselves in our centers trying to improve, reverse, or stop progression of disease. The most routine diagnoses that we see in cardiac, pulmonary, and vascular rehab, or for the remainder of my talk, I'll call CPRS for short, are heart attacks, coronary interventions. So if folks have had stents placed or angiograms with intervention, open heart procedures, CABG, valve replacements, heart failure, heart transplant, and even stable angina. On the pulmonary respiratory side of things, we see folks who have COPD or other conditions of the lungs, so interstitial lung diseases, fibrosis, things of the like. And most recently, CMS has approved peripheral artery disease. So this would be blockages of the vessels elsewhere in the body outside of the heart and brain that we use now in clinical supervised exercise training. So there we go. The stage is set. These are the populations that we serve. And that's a little bit about our day-to-day. So the value of these services, I think, is really important too, because if you're trying to weigh out a career as a CEP, one thing that was really important for me was being able to get some benefit from my work. Who am I helping? What am I doing? What value am I giving back for my services? So the purpose and value of CPRS, really, at the end of the day, we're helping patients. This is direct clinical care. We're very hands-on in one-on-one settings where we are treating clinical disease and working with people on behavioral management. And this has a monumental effect on the downstream revenue cycles for not only the hospital, but also our patients. If they can do better in our settings, they're going to be less likely to readmit to the hospital, come back for subsequent procedures, and really make big changes in their quality of life. So in that way, we decrease the need for maybe more high cost surgeries or interventions, like going to the cath lab. If we can set up an intervention and benefit them, we can keep them from readmitting into the hospital. We can give them cessation, tactics if they're trying to quit smoking or manage diabetes. So really help with the behavioral aspect of their care. And all of this is really targeted, as I just said, to improving the quality of life and really just trying to create a lifelong healthy lifestyle for these patients, especially for those who are finding themselves in adulthood and older adulthood wrestling with chronic disease that's having a profound impact on their life. So if we think about traditional cardiac rehab, there are about 4 phases of care, for individuals that come through, and I guess we could say that this is appropriate for our pulmonary patients as well. There's always the start of that first treatment or that acute event. So if we think about cardiac rehab, that would be the heart attack, right? So that initial event that brings someone to the hospital. After that, this is where secondary prevention programs come in once the intervention has been done or the surgery. And then patients move into the early outpatient cardiac rehab setting. So this would be formal training that they would receive through exercise therapies. We put the monitors on them, we monitor their EKG, give them an exercise prescription, and that phase of care. And beyond that, they can move into long-term cardiac rehab or secondary prevention programming. So the big question is, where do the CEPs enter into this scope, or what we would call the continuum of care for this particular event? Well, in my centers, my CEPs enter in the 3 latter phases. So initiating secondary prevention programs, we will start intervention with patients within hours of them coming out of the cath lab or coming out of the surgery theater. So for our CABG patients, we could have them up and walking and be interacting with them, like I said, within hours of their surgery, so that we can optimize outcomes, keep them from readmitting. This is really where we first start interacting in phase 1, what we call phase 1 care. So that's at bedside, and that would be early mobilization in an inpatient setting. Early outpatient cardiac rehab would be the next step. This is where we will do formally kind of the formal monitoring with EKG while patients are undergoing exercise therapies. We write their exercise prescriptions, do patient assessments, etc. And then our long-term phase, where we interact in our phase 3, phase 4 programming, is for patients who want to continue to use us as a medical fitness model. So we continue to give them annual exercise prescriptions, work with them on risk factor modifications, particular challenges that they might have. So you can see here in the hospital setting for CPRS, we are really engaged in a lot of the continuum of care, basically everything outside and after surgical intervention. So our field is changing quite a bit each and every day. We have to adapt as CEPs to play the healthcare setting. And one thing of late that has been particularly important for our services is focusing on something that we call value-based care. Basically what this is before, departments like mine used to look at the number of patients that they would serve. How many people can we get in and take care of? Value-based care puts much more focus on the quality of that care. And in that way, we work as CEPs, not only as individuals trained in exercise and behavioral modification therapies and intervention, but we work with multidisciplinary teamwork across not only our department, but other departments in the entire hospital. So it takes a large amount of care coordination. I think that this is really important to point out, because we can sometimes think of our particular training and our skill sets as being unique and appropriate for our patients on a very personal level, but we are looked at in our settings as the experts by our providers, our advanced care nurses, to deliver these therapies to patients that are going to have a big impact for them down the road. So we really kind of fall into this cycle of care where we're working side by side with our providers, and we're working as clinicians. We're working as care coordinators. We have to talk to other departments. We may be working with our heart failure units. We may be working with our cath labs. We may be coordinating with home health. We're coaches for our patients. We're case managers for our patients. Not everybody just is here to get an exercise prescription and walk out the door. They may be dealing with something that's more intimate related to diabetes or blood pressure management, and they're looking for us to be able to coordinate that care and ensure that they're receiving a comprehensive overlook at the time that they're with our hospital and really our network. And we're also counselors. We're there to help them. We're there to be their friends, their confidants, and the people that keep them accountable throughout their treatment phases. So, I really like to point these things out because it is so much more than exercise. We work in a very, very diverse way within our health and hospital networks. So let me take like my last couple minutes here to break down some specific job duties. So in cardiopulmonary rehab for pulmonary, vascular, cardiac, whichever the particular domain is, we have 10 components of care. And these range from patient assessment to exercise prescription. And as you can see on the screen here, a myriad of different risk factor modification techniques. So everyone's going to come in a different way. All of our patients have different needs. So it's very important to point out that as CEPs, during the patient assessment, our main goal is to identify the individual needs that our patients have. Where some patients may need particular attention to weight management, others may not. Tobacco cessation may be a particular concern for one patient where the other is a non-smoker. So it's very vital for us to be able to have a comprehensive overlook and a very deep understanding of each one of these particular settings. I'm not going to labor each one of the duties. I'm going to put them on the screen so you can see a little bit of a breakdown, but I will highlight some of these. But this is our day-to-day as a CEP in cardiac, pulmonary, and vascular rehab. During patient assessment, we have to do health histories. We have to do physical examinations. With our PAD patients, we're checking and looking at foot and wound care. We have to have an intimate knowledge of EKG to understand the inner workings of the heart and maybe some of the maladies that are present when they come to us secondary to their event. Many of our patients have comorbidities, so they're diabetic, they have high blood pressure, they may be struggling with cholesterol. We have to be able to educate them. We have to be able to know the normal limits and what those implications are going to be when they begin to exercise. Psychosocial management is becoming more and more crucial in our settings each and every day, particularly now highlighted by high stress environments during COVID-19 and a lot of the changes that we're undergoing. But you got to remember, when patients come to us, this is a life-changing event they've just had. They're wrestling with things in a new and different way. So they not only rely on us to give them top-rate clinical care, they also need us to be able to help them work through some of the challenges that they have with stress management. And that might require strategizing and giving counsel to other services. And so really, where we are working one-on-one on that clinical day to day, we're also coordinating care and making sure that each one of these components is highlighted for a patient and they're receiving optimum care, even if that means facilitating additional referrals and working with other practitioners in our settings. Finally, I thought I would just quickly highlight what I would think is kind of a maybe not totally unique, but one structure that I see quite often in cardiopulmonary rehab settings. And this is really just to highlight some of the job roles that you may be able to find yourself working in as a CEP. Everything I'm showing on the screen, a CEP would be qualified to sit for within a hospital setting. So program directors, now these are individuals that have the broad oversight for program direction, operational duties, payroll, some administrative stuff, but still getting out on the floor and working one-on-one with patients. As you go down the ladder, Supervisors work in a role where they have oversight on the floor and some of the day-to-day, may also be involved with payroll, but they would have direct reports. So for larger teams or larger cardiac rehab settings, you could see supervisory roles and opportunities. Clinical coordinators, these are individuals in our setting, particularly who are my standout care coordinators. They're individuals that are really good at making sure that referrals get sent to diabetes management, and to some of the other siloed services within the hospital that our patients might need. And they have ownership of day-to-day clinical practices and really are the content experts, making sure that new members of the team are able to tap into the resources that they need. EPs, so CEPs, would be what we would consider our exercise physiologist level 2. So these are our master's prepared individuals. And they also in our settings work as stress test supervisors. And then our EP1s would be our bachelor's prepared. But there are some differences, large stark differences between our clinically trained folks and our base EPs and the duties that they perform day to day and some of the opportunities that they have for reimbursement in our settings. So there you go. I went a little bit over my time. It is a big challenge to try to give you 10, 12 minutes of everything that a CEP does in cardiopulmonary rehab, but I would be happy to answer a few questions should we have them.
All right. Thank you very much, Matt. We do have right now one question from Kyle.
It's an easy one.
Yeah, Kyle did type his question, but Kyle, why don't you go ahead and unmute and ask in your own voice?
Yeah, I was just curious if you had to take any kind of like specialized courses to be a cardiopulmonary CEP, or if like your bachelor or master's education prepared you for more of like a general job setting, and then you're able to branch off wherever you pleased.
Yeah, good question. And I think if I'm following you, I'll answer it this way. You know, I am a master's prepared CEP. And in my opinion, that really has set me up to work in a diversity of hospital roles. Really, as a CEP, you would be able to walk into any cardiac or pulmonary setting and really be able to hit the ground running. Now, there's a little bit of a difference in center to center on what the specialty may be. I did not need any specific training for my roles, but you know, my center is one that does a bulk of structural heart. So I did have to do a little individual study just to get myself caught up on what's going on in the day-to-day with a lot of the valve work that we're doing and some of the implications with exercise. But all of the training I received as a CEP was a very strong base to be able to do that myself. So no additional training was really necessary beyond that master's preparation. Hope that answered your question.
Yes, it did. Thank you.
Yep.
All right. So I think in the interest of time, so that we can get to our speakers, we will move on. If you look on our agenda on our website, originally our next speaker was going to be Mark Patterson. Well, Mark, actually, because of his role as a CEP, has been working lately with some long haul COVID patients, wasn't able to actually be here in person today. He did record his session, however, but because that is a recorded part, which I will play, I want to get to our next live speaker. So our next speaker is Dr. Laura Richardson. Dr. Richardson is currently the CEPA president, as well as faculty at the University of Michigan. Additionally, she is a clinical exercise physiologist for Summa Health in their Bariatric and Weight Management Institute. And today, Laura will be talking about the area of bariatrics and metabolic disease. Laura, take it away.
Hi, thanks so much. Thanks, Prince. So just like Dr. Hargan's just introduced me, I wear two hats. Right out of my master's degree, I went into cardiac rehab. I loved it, just what Matt went over. Worked in cardiac rehab for a long time, and then moved into working under obesity physician. And it was, oh gosh, almost 18 years ago, when before we had clinics that really are what they are now, obesity clinics. So I been in bariatrics for many years, as well as teaching academia. And I've been asked a lot about, well, what do you do as a CEP with obesity? Because so much of what we teach in the classroom is pulmonary and cardiac, and a lot of just, kind of what Matt said, kind of classic exercise physiology is cardiac rehab. And I loved it. And I took what I was doing in cardiac rehab and started building a behavioral modification, physical activity interventions with obesity patients. And I think it's really important to give you a little background on obesity, because that is changes really the way how we care with our patients. But historically, the perspective over time, societal changes have happened. Body size has evolved, and exercise physiologists working with obese clients, our goal is to really help build positive attitudes towards physical activity. And that's something that not all CEPs think about. We all love to exercise, which is why we're studying what we study and who we are, but it's not a general sense among society. So building positive attitudes, helping people adhere to exercise. I want all of you to recognize your own bias you may have towards bias, stigma, kind of negative views we may have towards people of size, because that's how we're going to break down barriers and become better clinicians. So in a nutshell, right, when we think about what is obesity, I'm not going to read this to you, but obesity has been well defined, and it is really difficult to pinpoint. There's lots of research that looks at BMI versus body fat distribution, but from an epidemiological background, it really is looking at just BMI. We're looking at what happens when we have excess body fat associated with a lot of impaired body function, dysfunction that leads precipitated to numerous other health conditions. It accelerates lots and lots of comorbid conditions. We know those as risk factors, and really a big burden on morbidity and mortality. So I think we all understand what it is. I also think it's important to let us all remember that it is recently been diagnosed as a disease. It just a few years ago, 2013, the American Medical Association came together and finally voted that this is actually a disease. And what has happened over these years, not that long ago, is it's begun to do a shift, right? This shift of insurance coverage and reimbursement for providers. It's making more awareness of bariatric, and whether it's surgical or non-surgical treatment, and really supporting the concept that it is a disease and we, CEPs, are here to help. So I think it's important to kind of mention to all of you that it's relatively a new diagnosis. So without going into too much of the historical lens, I think that there was a lot of finger pointing that once was in medicine of patients are obese because of lack of willpower, psychological stuff that's going on, people's choices. People were seen as weak or failure to have that, be able to be structured. And I think doctors back in the day were guilty of telling people you just need to eat less and exercise more. And you can tell people that. And if they're really struggling with what we know is morbid obesity, there's many other layers to this onion we need to unpeel. And that is the role of the CEP in a bariatric clinic, is really understanding methods that work to lose weight. And it is a multifactorial, it is a very abnormal endocrine and immune response that happens in the body. We're looking at treating adipocytes and the dysfunction of the adipose tissue, and it's not an easy fix. Right. So not kind of tell you all of the stuff, but a lot of these things you may be learning in classrooms. This is a logarithm that's taught really at more of a physician level, right? So this logarithm is kind of the big picture. I'm not going to talk about all of this, but I want to understand where we, the exercise professional, the CEP, fits in. And it's at really the bottom line. On the bottom line of this, you see all of these multiple options for obesity treatment. Very interdisciplinary, as Matt just mentioned, in cardiac rehab. A lot of cardiac rehab philosophy overlaps to how we care for someone who's obese. So looking at just that bottom line, this is focusing in that I want you to realize that when someone goes to a bariatric clinic, oftentimes we're starting in a non-surgical. So diet, exercise, it may be pharmacological. People may lose weight and be very content doing a non-surgical intervention. And obviously there also is the surgical intervention, which is what I'm really going to focus on today, which is what we're seeing more and more people with comorbidities having bariatric surgery and having improvement and resolution of type 2 diabetes and sleep apnea and lots of great quality of life changes. But as you notice on this line, we exercise people fit with the dietitian, we fit with the clinical psychologist and the physician. So it is a very interesting scale of how this treatment option happens. And, this is kind of the risk to cost benefit ratio. So people may start just with the lifestyle, diet, and exercise, and then they may go to the next level, which is diet and exercise and pharmacological. They may go in along with the dietitian with these very controlled, very low calorie diet. Again, has to be under medical approval. And then we have the surgical. And the surgical is what we see and what has been proven to be very effective. So very effective long-term weight loss management, which is why we see so many people opting for bariatric surgery. Again, I don't want to spend a lot of time on this webinar going into the criteria, but there is very specific criteria and consensus among the National Institutes of Health with the physicians on who's a candidate for bariatric surgery. What are some of the things that have to be present in order to undergo the surgery? So again, that's something that you learn, and we play a role in trying to screen. This slide is just simply two of the surgery options. There are more than just two surgeries. So when you think about what is the quote bariatric surgery, a lot of times we think about just the first photo, the Roux-en-Y. It also could be the sleeve, and there's many other variations of these as well. Bottom line, bariatric surgery is some mode that the surgeon's going to go in and alter the stomach and the intestine to be able to hold less food and uptake less calories. What we need to know about this is it is a pretty quick turnaround to getting them back on their feet and exercising. So when I think about students and people looking for a career option, when we think about obesity and we think that someone is going to be in an obesity clinic and opt for surgery, physical activity is going to play a very important role. So I have this slide here that shows you three different columns, and I just want you to be aware of this as you're looking for internships, as you're looking to market yourself with your resume of who you're looking to attract. I would recommend that you find programs that are accredited from the American College of Surgeons. That's the ACS. They work very closely with the ASMBS, lots of acronyms. This is Metabolic and Bariatric Surgeons. And together there's this big accrediting body. And what all of this means to people like you and I is that there are standards that they're meeting. And one of the standards within this giant accreditation, which it would be in the larger hospitals, big clinics, doing a big volume, where you want to work, there is a standard in there that talks about how physical activity counseling is needed. So who is delivering the exercise information? Who is counseling patients on pre and post-surgical activity levels? So programs that are accredited are going to be abiding by these accreditation standards. The next column are physicians. I love working under physicians that are called diplomats. A diplomat is a physician who has passed a very stringent exam, and they are crazy knowledgeable, wonderful mentors, tremendous asset to how I prescribe and I treat my patients is under physicians that are diplomats. So again, this exists as well. If you've got your own independent personal training business, or you're working in a community setting, you want to be recruiting bariatric patients or obese clients, I want you to know who you should be reaching out to. And then the third column is something really interesting, because people who work, clinicians like ourselves, allied healthcare providers, dietitians, clinical psychologists, physician assistants, social workers, there's a list of healthcare providers that with years, this is not an entry level certification, but with years of experience, you can become a clinician with the specialty that's kind of under the umbrella of the Commission on Dietetic Registration. And it's an interdisciplinary specialist. And again, a lot of bariatric clinics are going to work towards having their employees board certified under this. So I think this is just good information on where do you find clinics to market yourself and perhaps maybe one day work under. This slide is what we know. All of us sitting here know that exercise is very impactful on body composition, on helping someone lose fat and retain muscle. It helps with insulin sensitivity. We know this, right? We know that exercise is imperatively important for healthy living. What I want you to realize if you choose to work with obese clients is that's a really important thing that we need to understand, that there's barriers there that maybe you and I don't have. Barriers to exercise, this oftentimes a psychosocial component that we have to be able to understand And this follows a lot true in cardiac rehab and pulmonary rehab as well. But what are some of the barriers that people give for not exercising? So during an assessment, which is what a CEP is going to be doing, we are looking to give an individualized treatment plan, right? So just like you saw Matt go over all of those comorbidities or risk factors, when were pivotal times in someone's life that they gained weight? Were they ever once active? If so, what did they like doing? What type of environment do they want to be exercising in, alone, in a fitness facility? We want to really understand a lot of barriers so we can design a program and counsel someone effectively, right? Just telling someone to go exercise, it doesn't work. Right? You know that that's not what we're telling people. But with that comes with a lot of complexity. And this is where it overlaps, bariatric surgery overlaps a lot with bariatrics, as it will do with some of the other talks you're going to hear in a little bit, is that these patients have chronic disease. They have multiple problems that they're juggling. So this multifactorial balancing act is what we need to be doing. As a CEP in bariatrics, it's important to realize that we will be doing both preoperative, so pre-surgery intervention, and post-surgery intervention. Because going through a bariatric journey, it's not just like you just call up and you just have surgery the next week. It's months of appointments. So through these months, we are giving them activity counseling, changing their eating. It's a slow process before they're going to be eligible for surgery. And through that, we want to be able to look at what contraindications are present. What are other things we've got to be working on? Are they on oxygen? Are they having, intermittent angina and taking nitro? Are they so morbid obese that they're homebound? And we're looking for activity programs that they're doing as non-weight bearing in a chair. So there's lots of assessment things that we're going to be working in. So when you think about what does the prescription look like? What does an exercise prescription look like for someone who's working in a clinic? We are spending a lot of our time, as you just mentioned, pre-surgical. So this has been found in studies. There's many studies that have documented and supported by the American Society for Metabolic and Bariatric Surgery recommends pre-surgical behavioral changes. So we are trying to get our patients to be exercising a minimum of 20 minutes, 3 to 4 days a week. I know that's not what we're telling the average healthy people, but we're trying to get them to become more active, to increase their cardiorespiratory fitness. This is along the lines with the American Heart Association saying the same thing. Then they go into the hospital and they have the surgery. During hospital stay, they will be up walking in the hospital. They're home for about 4 weeks healing. And after about the 4-week mark, it's when most of the surgeries are done laparoscopically. So there's not a very big incision, and the healing time, like I said, 2, 3, 4, maybe 6 weeks at most. They are then sent to full-fledged exercise. So our programming between pre-surgical and post-surgical is going to change. They're going to weigh a different amount on the scale. Their ability is going to change. So post guidelines look different, right? So our ASMBS, that Metabolic Society I talked to you about, the Obesity Society, the group of endocrinologists, all of these great, physician-based organizations recommend both preoperative and postoperative to adhere to physical activity so we can be achieving optimal body weight, we can improve body composition, and we really can help somebody maintain long-lasting weight loss. What does the exercise prescription look like? Again, well, these are numbers you've read right out of your ACSM guidelines book. This does exist. What I want us all to realize is that when you're working with someone who's of size, obese, morbid obese, there's a dose-response relationship. So evidence points that the dose-response relationship between physical activity and weight loss, meaning that higher levels of physical activity translate to greater benefits. We know that. And this is going to change over the journey of weight loss, right? So it's going to be hardest pre-surgical. It's when they weigh the most. There's going to be usually a lot of orthopedic aches and pains happening. Cardiorespiratory endurance is going to be low. And then as time goes on, obviously weight loss and their program is going to look different. When you think about a CEP getting a job in a bariatric clinic, guys, this slide kind of is where we fit. So this slide is showing us that data supports that a good 80% of our patients are going to be successful, going to be able to lose weight, keep it off, smooth sailing. But this other 20% that fit into this therapeutic window of exercise, of course, my dog is barking when it's my turn to talk, is where the CEP is going to be called upon. So when you look at the patients that are not achieving the weight that they should be achieving, this is where we come in, and we're doing a lot more one-on-one. We're doing a lot more behavioral counseling with the patients. What is it that we're giving them? We're giving them exercise, because when we can get somebody who's not achieving the weight loss, we call this the catalyst. I'm sorry, let me mute my thing for just a minute. Oh my goodness, I'm so sorry. There's someone at my front door and I'm home alone. Welcome to virtual learning. Anyways, so the catalyst is that exercise ignites all of these changes, the changes with insulin and resistant cells. And before we know it, we are going to be able to help the person get over that, what we call plateau in the world of bariatrics, and hopefully get them to be able to lose the fat and maintain and gain some muscle mass. So exercise, as we know, is really important. Personally, the clinic that I work in, again, I'm under supervision of a physician. Many fitness professionals, however, also play a role in how successful our obese clients are. So this happens in a hospital, but they're going to go out into the community center. And that's where many, I find students, I find entry level, undergraduate and graduate level prepared students finding, as fitness professionals, playing an integral role with supporting bariatric patients. So whether you're in a clinic or you're out in a community setting, I want you to remember it is multifactorial. We're looking for lifelong physical activity. You are one of the many members of the healthcare team providing exercise. And it's important to realize that it's intermittent is what works best. And that's not always what we get enough out of in our textbooks. But when you're working with sedentary, deconditioned clients, intermittent, slow exercise accumulating over time is the way we have been doing it in our clinic. I think it's important also to state that in the research is lagging. We don't have a lot of evidence-based research like we do with cardiac rehab, right? For 20, 30 years, we've got great data on cardiac and pulmonary patients, the bariatric patient, the cancer patient. A lot of these other areas are coming slowly for us to have evidence-based standards. So what we're doing right now is a lot of low-based intermittent exercise to really try to get the clients up and moving. Working with bariatric patients is an incredible journey. I think I like it just as much as I did in my years working in cardiac rehab. Working together as a team with the dietitian and clinical psychologist, understanding that it's more than just what they're doing physically, what are they eating, what's going on in their brain. This very multidisciplinary team approach is really who I am as a clinician, as a CEP, and how we fit into the big picture. So I probably went over, especially having to meet with my barking dog. But I always say that surgery is the tool and we are the insurance policy, right? A little corny, but it works, right? Getting people to move is what's going to make sure that the tool that the surgeon's doing in their digestive system is really going to work. So I will gladly take some questions. I have up here a member, as Dr. Hardin said, please think about becoming a member to boost your resume. But I will pause and see any questions anyone has.
Thank you, Dr. Richardson. Again, if you have a question, go ahead, put your name in the chat to me, and then I'll call on you, and you can unmute and ask your question. I'll ask Laura one thing, is in working with your clientele, describe a typical day of work, Laura.
So we do a lot of group, do the volume. So the clinic I'm in is high volume. So we don't have a lot of time to do one-on-one. So in the beginning, you will have a exercise, kind of a education sessions. We do a lot of large group education sessions, the dietitian, myself, the psychologist, where you're just giving them a lot of information in what kind of a classroom situation. So we're trying to give, so it's a lot of talk, it's a lot of teaching. So I will do a lot of delivery of how to exercise, how to understand step counts, how to choose a gym, a lot of exercise demonstrations with seated exercise. Counseling will continue post-operatively, and that's where then it would be more one-on-one. I do a lot of tandem appointments with the psychologist and myself working together on one-on-one with patients who aren't as successful. So a little unlike cardiac rehab, we're not giving them, we don't have the facility, and most hospitals don't, to give it like actual exercise inpatient. It's more of a, what do you need to do to be successful? Go home and do it and come back with questions. So it's a lot of classroom teaching, following up on phone calls, meeting patients individually for appointments, or doing team approach with either the psychologist or the dietitian. I love it. People, and this is a really great population to work with. They come in usually with very negative attitudes towards exercise, and give them 6-9 months later, and they will tell you these great success stories, right? Running 5Ks, joining the adult, basketball rec league, really inspirational to be able to be a stepping stone in patients who can transform their lifestyle. They transform obviously with the way they look. So that's kind of the way it looks, the CEP in most large clinics, you're doing a lot of talking and teaching.
All right, we'll do one question from Kushik, and I apologize if I'm pronouncing that wrong. Isanya and Catherine, I have your questions. We will save your questions for once we complete the other speakers, but I have you in the queue. Kushik, feel free to unmute and ask Laura your question.
Thank you very much. So I'm currently pursuing physiology and nutrition of sport and exercise with a lot of focus on sport, but I would like to get into the clinical realm. Would it be possible to not switch over actually, will I still be considered employable in the clinical sector? That is number one. And the second question is, if I'm not, will it be okay to take ACSM's CEP certification? Thank you.
No, those are good questions. So it is in the field of exercise science and kinesiology. There's a lot of overlap, and depending on what university you're at, you may be getting more human performance classes, peak performance, healthy people, and you may not be getting a lot of chronic disease. And that's really where the internship comes in. So, I would encourage you to do a clinical internship. You might start in a cardiac rehab. Cardiac rehab is cardiac rehab is a great environment to learn a lot about how everything juggles. So if you were to do a clinical internship with your degree, your undergrad, and for most of these CEPs are master prepared, even if it's not what you feel strong about, the internship is really going to give you all of those things professors along the way may not have had experience doing. So, that is kind of like myself. When I got my master's many, many years ago, I knew a little bit how to read EKGs, but not much. And it wasn't until I went to the cardiac rehab setting that I was like, oh, I really get this. So I would encourage you to keep at the degree you're going at and just try to find a clinical internship under chronic disease. So diabetes and heart disease and pulmonary disease. As for sitting for the exam is going to there's going to be a process of taking a look at where's your degree from, what classes have you taken, how many hours of internship do you have to sit for the CEP exam. So it's really meant that we're trying to encourage people to come into the world of CEPs and not turn people away because they had more coaching and sports performance instead of chronic disease. So hopefully that's a positive response for you. But a lot of students, I think all of us on the panel would speak in the clinic. We get a lot of students that come in and don't even know how to do a blood pressure. That's okay. We're going to help you. So that's the nice thing about internships, is that we're pretty cultivating and helping to learn all the things that professors don't have time to teach you in the classroom. I don't know, Matt or Dennis, do you have anything to add to that?
It's a loaded question, but I agree with you. Yeah, shoot for the internship. Get a little bit of clinical background. It'll be beneficial. You can absolutely transition.
And just to echo what Matt said and you said, Laura, I think that clinical internship is really the differentiator. A person earlier asked about, what classes or what do I need to prepare to be a clinical exercise physiologist? And of course, there's the ECG and exercise stress and maybe a pharmacology class that you can get in your master's or even undergrad. But it's really that clinical experience. And so really looking at a full internship is going to be invaluable, regardless of which direction you go in the field. And obviously today, we're talking about many different options.
No, that was a good question. Thank you. I will mute and we will move on, but we will take more questions at the end.
Yes. And what a great transition with Dr. Kerrigan finishing that question. We will move on to our next speaker, Dr. Dennis Kerrigan. Dennis is a past president of CEPA and currently director of the outpatient exercise programs and weight management at Henry Ford Hospital's main campus in Detroit, Michigan. He earned his BS from Bowling Green State University, his MS from Eastern Michigan University, and PhD from Ohio State University. In his current role as the director of outpatient exercise programs in preventative cardiology, he oversees the EXCITE program, a comprehensive evidence-based clinical exercise program for patients with a history of cancer. It is this experience with cancer that Dr. Kerrigan will be speaking about. Dennis, the podium is yours.
All right. Thank you, Trent. So just like the other speakers had mentioned, and Trent as well, my background initially was in cardiac rehab, and I'm still involved in cardiac rehab. Once a week I'll do stress testing, usually in heart failure or patients with CAD. And I mean, initially I was looking at physical therapy, like maybe some of you out there, when I was first thinking about the field and what I wanted to do for the rest of my life. But interestingly enough, we started a bariatric exercise program. So just like Laura talked about it. So I got involved in that. I got involved in doing research, which I thought was a lot of fun. And then I went on and got my PhD thinking that I was going to emphasize on obesity and weight loss and helping patients along those lines. It turns out as I was getting ready to graduate from Ohio State, an opportunity came up where I could come back to Henry Ford because they were looking at starting a new exercise oncology program, which again, I had no background at all, no real interest. My interest in cardiac rehab was my dad had a heart attack and he went to cardiac rehab and he did really well. But with respect to exercise oncology or oncology in general, I knew absolutely nothing about except for the fact that I had a job opportunity. And so I dove into it. And it was interesting from the standpoint that when I first started to learn about oncology and exercise oncology, the field of exercise oncology 10 years ago was similar to maybe cardiac rehab, 30 or 40 years ago, where, it wasn't well known. And really, when we look at, kind of the standard of care for patients back in the 60s after a heart attack, it was bed rest and no exercise whatsoever. And when I started to dive into, exercise oncology, I heard a lot of this message, from clinicians: rest, take it easy. Oh, we don't want our patient doing that. And so over the past decade, and I'm going to get into the whys, we've seen a lot of change and really a lot of opportunities, as I'm going to dive into, for hopefully, those of you that might be interested in this field. And I found, as I mentioned just a moment ago, there's a lot of similarities. And at the end of the day, hopefully you're in this field because you like working with individuals, you like helping them, and you like exercise. So if you like those things, this might be the right place for you. But anyway, I guess I should move on to my next slide here. So starting off, just to give you guys some background, first of all, the good news, and this is what I always emphasize with my patients, is, cancer survival rates have never been greater. There's more than 17 million cancer survivors in the United States. So because of better treatment, better detection, patients are living much longer than they ever have before. Unfortunately, when it comes to cancer and its treatments, and maybe some of you, have family members or know people who've gone through chemotherapy or radiation, it's really tough. And so there's a lot of side effects associated with that. And interestingly, even though patients are not dying as much of cancer as they did in the past, we're seeing a shift where patients are starting to die more of other diseases, particularly heart disease, which again ties in nicely in terms of the cardiopulmonary rehab. And why this happens is a multitude of factors. First of all, we know that there's direct impact from the cancer treatment itself, whether it's radiation on the left side, which, breast cancer radiation that can affect the heart if it's left-sided breast cancer, or chemotherapy drugs like adriamycin that can actually attack the heart muscle and cause heart failure. So we know about those. And so it's important to understand, what the treatment regimen of patients are. But as I just said a moment ago, we also know that there's a lot of indirect injury as far as, you feel terrible, you're sick, you don't feel like getting up and moving. And we know that if you take anybody and you sit them around more, that's not good for your health. That's going to decondition someone. It's going to cause them to gain weight. And that within the context of most cancer patients we see, they're typically going to be older, they're typically going to have pre-existing, risk factors like diabetes and hypertension. These individuals, it's kind of a perfect storm in terms of them moving towards more disabilities. And again, as I mentioned, have a much greater risk of cardiovascular death. So again, as you guys all know out there, because you study exercise physiology and all the great benefits that you get from exercise, all these things that I talked about can be attenuated by regular exercise, whether it's improving fatigue or improving cardiovascular risk factors or whatnot. And, since the time when I first started to get involved in exercise oncology, there's been a lot of research, and we've done some research here at Henry Ford also, looking at the many, many benefits of how exercise can improve symptoms. And so much that I feel like we're at the point right now where we don't have to spend much time convincing people that exercise is good for them. Really, and this is a discussion you don't have to have with the oncologist either. They understand the value of it, the benefit of it. But the challenge for all of us in this field is how do we deliver? And that's really where, I wanted to focus, the rest of the talk is how do we translate all this great information that we know that exercise can do into, put it into a practice that we can actually help individuals. Now, it's not as easy as cardiac rehab because, there's not very many exercise oncology programs throughout the country. I can think of about, maybe just a handful of them, including ourselves. And like I know the Maple Cancer Institute down in Ohio is another good one, or the Rocky Mountain Cancer Program is another one, but there's not a whole lot of them. And so really when we talk about, what's this, secret sauce in terms of, helping develop an exercise oncology program, well, you don't have to look any further than to cardiac rehab, and really, the key ingredients and some of this, maybe you don't need to be concerned of just coming into the profession, but, when we talk about clinical programs, we need to have hospital administration support. That's the first step. We need to have champion physicians who refer patients and help talk to other physicians on our behalf. And then we need to have exercise facilities, expert staff, which is all of you, support staff, which is very important because we can't do everything, and then funding. And this is also where I think that, it is important to stay connected to our roots in terms of cardiac rehab. And because, at least in my case, and there are exceptions out there, we in our case, we had the framework and foundation of cardiac rehab to help our cancer program. Excuse me, someone keeps trying to call me. I'm just gonna hang up on that person. So I apologize. Laura had the dog, I have this phone, okay? But anyway, so again, starting a exercise oncology program from scratch can be very tough. However, using cardiac rehab can really help, because again, you have that infrastructure in terms of you have the staff, you have the equipment, and then you have the administrative support. So just to kind of give you an overview of what the Excite program looks like. First of all, we started from some philanthropy funding, and we are supported annually from a fund called Game on Cancer. So even though I joke with my patients that sometimes it can be hard to cheer for the Detroit Lions or Pistons because they're in last place usually, they do support our program, and they help subsidize our program from the sense that, our patients who come into exercise they don't have to worry about financial barriers. And that's a big challenge, because when we talk about, cancer patients during treatment, it can be very expensive for them. I don't know if you've ever heard of the term of financial toxicity, but that's something that's usually brought up when we talk about cancer patients and all the medications and appointments and stuff they have to go through. But we can, again, help circumvent those barriers. Additionally, our program, we run about 4 or 5 cancer exercise classes a week. Because of COVID, it's really kind of shrunk our class size down a little bit. But we run it very similar to what we do with cardiac rehab. So patients will come in, we'll assess them. If they're hypertensive, we'll take their blood pressure. We'll see if they've had any signs or symptoms, or if they've had any issues since their last treatment. And then we have an individualized exercise program, which incorporates both aerobic exercise, strength training, some stretching, and again, education. So, and as Laura and Matt discussed, we are part of a multidisciplinary program. So as a clinical exercise physiologist, you don't work in a silo. You work with nurses or physicians and you communicate with them. And so having, a good understanding of the cancer pathophysiology and the medications are very important, so you can clearly communicate. Also, as I mentioned earlier, a lot of our patients, they're at risk for cardiovascular disease. So I end up bringing them over to my stress lab, and we do exercise stress testing with some of them. I work with a cardiologist who specializes in cardio-oncology because we have that crossover. So anyway, that's kind of hopefully gives you in a nutshell of what our typical patient might look like and how that works. So finally, I would encourage each of you to do your own homework. As I said, I think there's a lot of opportunities on the horizon for exercise oncology. I feel that maybe within the next 10 to 15 years, we're not going to have to worry or depend on philanthropy funding for this. This will be a covered CMS benefit, and it's headed in that direction. Just like CEP PAD was something that was, finally there was research behind it, and then it's approved as a covered condition, which a lot of times, again, it's under the umbrella of cardiac rehab. Cancer rehab is well on that way. So you want to really dive into it. Maybe at your university, there might be an exercise oncology class or specialty. A lot of times there isn't, so you may want to look to ACSM and some of their resources. I was certified through the Rocky Mountain Cancer Institute, so they have a great program where I spent a week out there and learned from them, and we kind of took what they did there to Detroit. So again, it's important, to educate yourself on that. So, and like the other callers or presenters, I probably went over my time. So I'm going to stop right here and thank you for attention, and let me know if there's any questions.
Thank you, Dr. Kerrigan. There is. The first question is going to be asked by Rob Brown. Feel free to unmute and ask your question, Rob.
Hello, Dr. Kerrigan. Thank you for that information. Full disclosure, I'm actually an employee of MD Anderson Cancer Center in Houston.
Oh, sorry to mention your name, but you guys have a great program there too.
I'm actually a data scientist there, but I have a master's degree now in exercise science. My question is, would it help to get the ACSM-ACS cancer trainer certification prior to landing a job, or would it be better to get experience and then possibly get that certification?
I think it's always good to have that ahead of time, because you're showing your employer you're taking initiative and this is what you want to do. Personally, I didn't have any cancer certifications until I found out that that's what I was being hired for, and then I jumped into it. So I mean, it certainly works both ways. But yeah, I think if you're thinking about it, that's probably a good place to start. And you have a cardiologist out there, and her name escapes me right now. She was on a circulation Susan, I think is her name.
Yes, and I'm blanking on her name. I also know the physiologists that work for her.
Okay.
But
I'm gonna say she's the person you need to talk to. Yeah, her and I have collaborated a little bit, and we're actually trying to work on an NIH grant.
thank you for your information, sir.
All right, thank you.
All right, next for a question for Dr. Kerrigan is Nicholas Foggia. Again, apologies for pronunciation of your name, but feel free to unmute and ask your question.
Hi, yeah, it's Foggia. You got it pretty close, but I appreciate it. Everyone kind of botches it. But no, my question for you, Dr. Kerrigan, was you kind of mentioned the barriers behind getting a program like this started, and I graduated from St. Francis University with my master's in exercise oncology and cancer care. So I've been trying to start my own program. And you brought forth some very helpful and unique kind of information in terms of using the cardiac rehab model format and pathway to go ahead and do that. Is the first step just kind of, banging on doors, not banging on doors, but knocking on doors, and just trying to find someone who will buy in, to this? Because I feel like the resistance or the lack of willingness to go ahead and buy in is kind of like that biggest barrier to this. So is that the first kind of step, or is the first step maybe having like an infrastructure that you can present to someone about like an integrative approach, because it is a bit of a tough situation. As you said, there are not too many programs out there that go ahead and tackle this type of work. So I know it's a bit of a loaded question. So thank you for your time.
Oh, no, that's a great question, Nick. So yeah, for sure, you're ahead of the curve. And as I said, if you go to any oncologist or hospital administrator and you talk to them about the importance of exercise for cancer patients during treatment and survivorship, they're going to nod their head and they're going to say, yes, we need this. But again, having that infrastructure is where maybe, getting into maybe a cardiac rehab at a facility and say, I'm really interested in doing this. Sometimes it can be done through like the phase 3 or maintenance program, and just again starting a network. And obviously you need to be able to have those individuals who can champion on your behalf. But I know that there was just a recent article that came out talking about prostate cancer and how the time is ripe now, but there's really still no guidelines. Even though we have guidelines for exercise and nutrition, there's no specifics as far as how do we, what is the framework in terms of putting together an exercise program and delivering it. So hopefully that was helpful, Nick. But good luck to you, and I'm happy to talk to you afterwards as well.
It was. Thank you very much.
All right, let's move on to our final live speaker of the day, that being Garett Griffith. Garett is currently the chair of the Career Resources Committee for CEPA, as well as a member of the Executive Committee, currently serving as CEPA's secretary. Garett has a bachelor's degree from Butler University, a master's degree from Ball State University, again, chirp, chirp, and a Master of Public Health degree from the University of Illinois at Chicago. He's currently a clinical research manager at Northwestern University, and he will be speaking about his role as a clinical exercise physiologist with that job. Garett, take it away.
Awesome. Thank you so much, Trent. Appreciate the opportunity to speak here with CEPA. It's great to see some of my colleagues on the panel as well. And it's good to see such a large turnout for this event. It's good to see that there's momentum towards interest in the CEP field and definitely the diversity of positions that are available to us in this field. So it's great to dive into that. I always like to start off with a slide similar to this, because if there's two things that I've learned in the field in clinical research as a clinical exercise physiologist, first off, it's certainly hard to explain to my family and friends exactly what I do. It's sort of a jack of all trades in a sense. It's not as concentrated in a certain patient population or patient cohort as some of my colleagues who have presented already. But second thing I've learned is it's also kind of a create your own adventure. It certainly has opportunities for advancement and going above and beyond. And I'll highlight my particular career and educational path, since like I said, it's definitely unique amongst each individual. And so individuals interested in clinical research, the sky's the limit. There's certainly plenty of populations that'll benefit. It was good to hear Dennis kind of talk about how the guidelines are evolving, how they're getting there, how different populations with oncology, with bariatrics, with cardiopulmonary have all at one point sort of evolved from a general understanding of exercise is good to more concrete recommendations towards more concrete coverages and those types of things. That all happens on the research side of things. So I'll kind of view some of the similar populations that we've already discussed from the lens of helping generate new knowledge, helping take a step back from the world of clinical care, and how do you work with clinicians, work with academics to build that bridge and generate and move the body of knowledge forward in that sense. We'll kind of dive in from that perspective. So my academic and professional background, diving into the field out of graduate school, I really wanted a job in cardiac rehab, took about 10 or so applications, 5 or so interviews, didn't really get any sort of offers or anything. So a job in research opened up, and straight out of becoming a graduate assistant at Ball State, was able to jump into a research specialist position, moving into a senior research specialist position. This was in the integrative physiology laboratory, which specialized in exercise testing and training of chronic diseases. So we worked with individuals with type 1 diabetes, breast cancer survivors. We worked with individuals with Down syndrome, individuals with inflammatory conditions, all hosts of individuals that, as we know, exercise benefits everybody. So we were generating new knowledge, focusing on autonomic responses to exercise. How do those individuals facilitate exercise with autonomic responses, looking at blood pressure, blood flow controls in those individuals? How do they differ from quote unquote healthy peers that might not have those conditions? And how do we generate guidelines, like I said, and help kind of move the field forward to help promote exercise in those populations? While working at UIC, pursued a Master of Public Health, as we talked about, in health policy and administration. Wasn't necessarily the most glamorous few years, working full-time, going to school full-time after hours. But as I mentioned earlier, it's really create your own adventure. So one of the morals of the story for my presentation is going to be really invest in yourself, especially in a role in a clinical research field. The way to get ahead, the way to kind of differentiate yourself and take leadership positions is to be proactive, present that data, go to conferences, go for additional degrees. Those types of things are really going to be pretty important in terms of advancing in the field of clinical research. After working at UIC for a few years, got into the Department of Neurology here at Northwestern University, where I'm currently working. Transitioned about a year and a half ago to the PT and Human Movement Sciences department. So went from a bit more industry-sponsored trials, which was a unique way to view research, more industry funded studies, looking with pharma companies, those types of rare, genetic diseases, more traditional interventional trials that way. Back into my, more comfort level of exercise testing and training studies. So right now we're looking a lot about Parkinson's disease, stroke recovery, cystic fibrosis. Once again, a jack of all trades, a whole host of different populations, helping inform decisions and protocols, working with MDs to get those protocols off the ground. So I'm currently working for my PhD, once again, to hopefully conduct my own research after this step is done. So here's a good example of a laboratory that is perfectly applicable for clinical exercise physiologists. Myself currently managing this particular laboratory at Northwestern. We do a lot of exercise testing and training studies for Parkinson's disease, looking at 18 months of aerobic training, looking at how that's impacting brain function, doing brain scans, doing quality of life assessments, cognitive assessments, fitness assessments, mobility assessments. So once again, kind of layering that patient care in terms of knowing exercise is good, helping facilitate exercise training, but trying to move that field forward in terms of, does this particular intervention significantly alter the disease course? Can we sort of replace or even improve upon effects that you might get from the stereotypical disease-modifying modifications in Parkinson's disease? With individuals with stroke, can we help regain function back? Can we regain muscular strength back? Can we help get bilateral movement back? Those types of things, because exercise is positively impacting these outcomes as we continue to learn as we go forward. I wanted to just spend a moment here talking about what is graduate school life like in this area. That was a big part of me winding up in a research career, was kind of diving into a research-heavy program. So Ball State certainly has a thesis requirement, has an intensive writing requirement and data analysis, taking biostatistics course, that type of thing. You might notice in this top picture here, Matt Thomas showed up in my graduate program. So he and I were in the same cohort here. So I think Matt has a similar perspective a lot of times in terms of the research aspect of how these sides of a career can help benefit the cardiopulmonary world, the oncology world, the bariatric world. There's certainly two sides of the same coin informing decisions going forward. So what skills have helped me advance in my career? A lot of the exercise testing and training studies that I've been involved with have been very aerobic in nature. Resistance training has been not as common, but there's certainly still resistance training based studies that are out there. This first slide, we have myself conducting an exercise training test, a cardiopulmonary exercise test with the full cardiopulmonary setup, doing gas analysis, looking at RPE, doing ECG analysis as well to ensure safety. Like I said, we do that full testing in heart patients. We do that testing in Parkinson's disease patients, diabetic patients, and then further being able to translate those results into effective prescriptions. You help inform the protocol. Should they be working at a moderate intensity? Should they be working at a vigorous intensity? Should it be based off heart rate reserve? Should it be based off max heart rate? Those are all questions that as a CEP, you're certainly qualified to answer. And it's been great to work with physicians and different researchers across campus who might have a good handle on a disease population, want to investigate how exercise might impact that, but don't really know how exercise prescriptions work. They don't really know how to meet guidelines or how to standardize this across different patients within a specific cohort or population that have different fitness levels. So helping translate those data, helping create meaningful protocols has been a really rewarding part of the career as well. In terms of resistance training, being able to conduct maximum resistance training, 1RM testing, different protocols to be able to understand muscular fitness, whether it's endurance or strength, being able to then translate that into a resistance training protocol, whether it's upper body, lower body, total body, how those resistance training programs will have to be modified over time, whether it's a midpoint assessment leading up to a final assessment. So once again, all the classes we've been taking in terms of exercise programming, any kind of sort of lifestyle courses, whether it's resistance training at the gym, any kind of PE-based courses for me were super helpful, but being able to translate those to a research setting has been super applicable. And then my career has really kind of layered a deeper level of understanding of ultrasound assessments, looking at arterial health, looking at things like brachial blood pressure, how that's impacted by exercise in different populations, whether it's high intensity interval training, how does that impact blood pressure following exercise? Those questions are all very answerable by CEPs in these kind of settings. Looking at blood pressure of the aorta, speed of blood flow going through the periphery or the central arterial system, all is very applicable skills to develop as a CEP as well. But as I mentioned, trying to get yourself out there. So I think the main takeaway from this presentation is try to go above and beyond, whether that's poster presentations locally, poster presentations at the national ACSM, all very valid ways to get yourself out there. Data dissemination is a huge part of this career because ultimately funders are going to want to see that your laboratory is making use of the dollars that they're giving you. It helps advance your career. It helps advance the PI that you might be working with. Trying to work through original research. This is an article I had published in the CEPA's journal, Journal of Clinical Exercise Physiology. So that was something that once again was above and beyond, but I think it's a big part of utilizing any downtime you might be having, utilizing any kind of initiative you might have in a research question that might be valid and answerable by the protocol you're working on is certainly a good way to kind of advance in this career as well. Taking that a step further, trying to give in-person symposia, so trying to put together sessions. Matt and I in 2016 at Midwest ACSM were able to throw an idea together and get on CEPA's clinical track for that Midwest ACSM presentation. I was able to also interact with Laura and another CEPA member at Oak Brook a couple of years ago, the most recently presenting at AACVPR. So once again, these things certainly not requirement of the job, but I think getting that exposure, being able to network, understanding what other labs are doing and helping inform future protocols, that's really best done in sort of a networking setting, being able to go ahead and do that, talk to other professionals, pick their brain, and they'll likely be doing the same for you as you get your name out there as an expert. So just taking a brief glimpse into what the career ladder might look like in different fields like this. It's important to know that different universities, different industry settings, different departments might have different terminology, but it's all generally similar. You can kind of see that people usually enter in a research specialist, a research study assistant based role, a research project coordinator. And as leadership skills are obtained and as leadership opportunities are pursued, supervising other research staff, onboarding them, helping with protocol development, analyzing data, doing quality assurance. These are all skills that help you move up the ladder towards laboratory manager, towards a project manager, towards a data manager. And in an academic setting, you can also take the route of professional student, being a PhD student, a postdoc, going into an assistant professor role, an associate professor role. Looking to do research as a career is very valid as well. That's where I consider myself going as pursuing this PhD. So all those things are totally applicable as, for CEP to make their way up those career ladders. Here's an example of the SPARKS-3 study. This is my primary study that I'm working on now, that Parkinson's disease training study. And I wanted to show this because it's a pretty unique web of roles, and there are clinical exercise physiologists that find themselves in various parts of this map. But things like behind the scenes infrastructure, looking at data coordinating centers, health and safety centers, the heart rate monitoring core, the exercise prescription core, the quality assurance core, people have to build the database. And so once again, as we're looking to standardize, as the studies get bigger and bigger, this one has 27 other sites on top of the few core sites, 29 in total. There are clinical exercise physiologists scattered around all throughout these different buckets here, myself included. I find myself showing up on a couple different cores and different core teams to help keep the standardization in line across all sites, because that's going to be important to be able to make sure that all sites are following the protocol, all participants are safe. Otherwise, the data in trying to translate it towards a clinical setting in shipping guidelines and helping inform practice, the meaning gets a little bit limited that way if you're not really strict with these types of things. So that's always going to be a big aspect of research, as well as kind of joining for the bigger teams, especially for these multi-site studies that way. So what does the day-to-day look like? A lot of recruitment and enrollment, oftentimes, depending on the particular study. If you don't enroll participants into a study, you don't get paid. That's different depending on whatever grant you might get, but a lot of times, especially in industry-sponsored studies, spend a lot of time with recruitment. It takes a little bit of time to get out into the community, to understand inclusion, exclusion criteria, to understand what the protocol requires. How do you sell it? How do you get into support groups to be able to tell them, hey, this is what we're looking for. Here's why we think it might be a good idea. Here's the benefits. Here's the risks associated with it. Transparency is key for these things. Working closely with MDs to confirm eligibility is going to be important. Any kind of exclusion or inclusion eligibility that might be violated, make notes of it, be very detail oriented to help kind of shape future studies of why was it challenging to recruit participants for a given study. These are all worthwhile pursuits, especially in this role as you're getting people into a study, depending on sample size requirements. Clinical exercise physiologists, obviously very well qualified to lead exercise testing and training aspects of a protocol, not even just implementing it once it's been formed, but helping through the entire process of IRB approval, working with the Institutional Review Board, which is a university's governing body of research, to make sure that participants are being protected, that there's no exploitation or unsafe harm that participants are being exposed to. So working with individuals from the IRB to make sure that they understand what the protocol looks like. If they have questions, you'll answer it. You know, what does this intensity mean? What does this exercise test mean? Being able to be that sort of conduit and being able to be that liaison between the study team as well as the IRB is going to help make your principal investigator's job way easier. So that's a good skill to have as well. And then in terms of more thorough regulatory documentation, being very detail oriented, any kind of sponsorship communications, whether it's the NIH, whether it's industry, whether it's, you know, the American Heart Association, all those different grant application type elements, all the, you know, annual reporting that's due, quarterly reporting that's due, whatever the grant requires. People, especially, you know, CEPs and these types of jobs, research staff will be certainly qualified to be that detail oriented, very thorough documentarians, people who are keeping tabs on all of the, you know, communications, all of the adverse events. If there are any adverse events to exercise, they'll be able to be a communicator that way. And I wanted to end on just some advantages of clinical research. It's certainly long days. It's certainly early mornings, because sometimes you have to test before the sun comes up based off participant schedules. But I think there are certainly a lot of perks of the job that I've learned to enjoy, and I've really been glad I've taken this career in this direction. So first of all, interacting with a diverse cohorts worth of patients. So I'm not necessarily as specialized in whether it's oncology or bariatrics or cardiopulmonary, but interacting with all those populations in a research setting, with preventive medicine here at Northwestern, with you know, cystic fibrosis with the pulmonary docs, all those different populations has been really great for me to continue challenging myself, to continue the continuing ed is a huge part. And then once again, being that centralized exercise resource for individuals around campus to help educate their staff, to help build protocols for them and find myself on those protocols as well. Lots of great networking opportunities at different conferences. Typically go to ACSM. I've gone to AHA a few times, experimental biology, AACVPR. And as you can see, all those networking opportunities lead to, you know, great dinners with friends, whitewater rafting on occasion for important lab meetings, as you can see. But overall, I've really appreciated the opportunity to be able to present that data, to submit abstracts, to learn, you know, more about diving into data analysis. I enjoy, you know, working at the computer a little bit, answering questions, seeing where the data might lead, helping inform the next protocol down the road. And those are things that I think, as we sort of started off saying, it's a good flip side of the coin, where down the road, these findings, you know, whether it's improvement in quality of life, mobility, fitness levels. That's what's going to be informing and really kind of guiding the way for clinical care down the road in these various populations. So it certainly takes a strong research team. Happy to be a part of it. Happy for everyone to have heard a bit about my day-to-day and sort of how I've progressed in it, and happy to take questions at this time. Thank you so much.
All right. Thank you, Garrett. Our next speaker couldn't be with us today, but has recorded his portion. His name is Mark Patterson. Mark is a clinical exercise physiologist with Kaiser Permanente in Colorado. He has a bachelor's degree in health and physical education from the University of Central Missouri and a master's degree in education/exercise physiology from the University of Virginia, which I don't hold against him as an alumni of Virginia Tech. Today, he will describe working as a clinical exercise physiologist who works with individuals with peripheral arterial disease.
Hello all. Sorry I could not be there live for this presentation, but between seeing patients for shortness of breath due to long hauler COVID, others concerned for it, and the fact that heart disease does not take a break during a pandemic, could not pull away for this. I was asked to do a presentation about what clinical exercise physiologists can do with their career, and my task was to present more specifically on my work with peripheral artery disease patients who suffer from claudication when walking or doing other physical activities. What I do feel is helpful when speaking to those who intend to pursue a career in our field is a bit on how I got to where I am today. The journey those take that are successful is many times just as important as the end result. In high school and college, I was a competitive runner in cross country and track, so I already had an interest in how the human body responds during exercise. I started at Simpson College in Iowa, had some injuries that ended my competitive career, and I decided I needed a change and transferred to the University of Central Missouri. At the time, they did not have an exercise science department. A couple of my friends and I were contemplating leaving for another university to get an actual exercise science degree, but the leadership in the department met with us and helped us develop what was called the fitness wellness track at the time, which was essentially the same classes that were needed for an exercise science degree. The changes ended up adding an additional 2 years to my undergraduate degree, and I decided I needed to take a year off just to work and take my time applying to graduate school. As many of us do, I worked as a personal trainer during that time to make some money. A couple of dozen graduate school applications later, I decided to attend the University of Virginia. I did start out with the intention of obtaining my PhD and work in higher education as my career. It took a turn after my first year, and I decided I wanted to work in healthcare. After graduation from University of Virginia in 1997, I took my first job at Hammond's Heart Institute in Springfield, Missouri. After a year in Missouri, I decided to make a move to Colorado, where I was born, and did not have a healthcare job secured at the time, so I worked as a personal trainer at 24 Hour Fitness and the Denver Athletic Club, and then worked at Experimental and Applied Sciences, or you may know it as EAS, which is a nutritional supplement company. While I was there, I did meet an individual who was the founder of what is now called Muscle Activation Techniques, and did some work for him for a time. Eventually, the company sold, and I had to move on. I was unemployed for a couple months, and I did various jobs, including selling computers, recruiting physicians to work in temp jobs, and then I helped manage a fitness center where I met a physician that worked at Kaiser Permanente, and he said cardiology was looking to make some changes. So I took it upon myself to walk into the cardiology office and ask to meet with the director. Fortunately, she took the time to sit down and talk, and thus we created a position for a master's degree clinical exercise physiologist in the department. I worked mainly in the stress testing lab, but did some education sessions for the cardiac rehabilitation team, which was a case management and education program and not your typical facility-based program. Our hospital partners ran that part for us. After a couple of years, I moved up to manager of the stress testing and echocardiography labs for about 2 years. I decided that management was not my gig, then sat down with the same director and hammered out a plan to develop a one-on-one consultation and evaluation program for our cardiology patients. So why did I want to develop this program, and why include patients with symptomatic peripheral artery disease? One of the big issues with the success of many cardiac and pulmonary rehabilitation programs was lack of referrals from providers and lack of easy access. Costs were increasing to members to participate, and many felt the need to return to work quickly, more than worrying about the recovery from their heart event. A quick look at some of the data from one of our hospital partners that ran our more traditional program noted 132 referrals, only 81 participating in at least one session, and on average, they were only attending 8 sessions total. You may all know that much of the success of cardiac rehabilitation relies on attending a lot more than 8 sessions. So there were some obvious gaps noted. In regard with those with peripheral artery disease, no one was including symptomatic peripheral artery disease at the time as an indication for this type of rehabilitation. And that was despite the fact that they are much higher risk for abnormal cardiovascular events and early mortality. So I set off to develop a new program. I was granted 6 months, a computer, and a desk to create this program. I decided that I wanted to include more than just typical indications for cardiac rehabilitation, but add those with peripheral artery disease and those who were just at high risk for future cardiovascular complications. So as you can imagine, this included a whole lot of people just over the age of 50. My proposal for this program idea was accepted, and a pilot was started in late 2006 and then went live in early 2007. So how does the program work? It was the same protocol for anyone I saw, but we'll focus on the conversation on those with peripheral artery disease. We have an administrative assistant who would scan hospital records for anyone with an indication for our services, and we would of course get referrals from the vascular surgery team. The nurse case managers would do an initial screening, contact the patient within about 48 hours of leaving the hospital or from their visit with the vascular surgeon, discuss how best to address their needs. Then they would make referrals to the appropriate teams to take over their care. Patients, of course, decided if they didn't want any more additional help, that they would do it on their own. That's fine. But we found that about 80% or more did want our services. As you can see here, all patients were enrolled with our clinical pharmacy program, where they had their own varied pharmacist who would help monitor the labs and medications to help modify their cardiovascular risk. Besides myself, there are a lot of other resources, as you can see, to help. After the referral was made and they were scheduled, they come see me for a 90-minute appointment. The initial part of this appointment was more a review of their medical history, current symptoms and limitations, and of course their history with exercise and recreation. The second part of the appointment was where I had many options and how I decided to work with them. There was no specific template or protocol, and I had the flexibility to do what was best for them. I would normally do some kind of aerobic assessment, and in this case many times I monitored them like a routine stress test while I was determining their limitations to walking, since they are considerably higher risk for heart disease. Over the years, on any given week, I would find about 10 to 20% of the PAD patients that I saw needed some sort of help with their heart. I can also do strength, flexibility, balance, gait, and other functional testing to develop the best plan for them. The last part of their visit was developing their plan, with them sitting right next to me while I typed out their plan on a computer. I felt this was a key part, as they really felt they were involved in the process and thus more invested in sticking to the plan. Once the plan was done, then we set the follow-up. It could be as simple as they would contact me as needed. We could do some follow-up phone calls or emails, or sometimes they come to see me in a follow-up office visit, which was less than a more traditional program, or sometimes it was just decided that they should attend a more traditional rehab program. Now that was originally reserved only for those who had heart problems, to about 2016 when our hospital partners started to see PAD patients. So how successful is the program? Comparison of how many patients came to see me versus the hospital program prior to 2016 was tracked in 2012. This was a comparison to 2 of our hospital partners who ran a more traditional program for our patients. As you can see, the total number of patients is fairly even. I saw more than either one individually. Also of note, they did not see even one PAD patient. So how about the effectiveness of my visits? 2010 to 2012, I used the Stanford Brief Activity Survey. 88% either maintained or increased beyond a moderate volume and intensity of activity. Of those, 50% actually increased. 88% of the favorable results were from increases in recreational activity. So it appears it was effective in helping patients reach their goals. What about the future? One of our projects in the works is establishing a virtual rehabilitation program. This would, of course, not be just for our PAD patients, but for any of our patients who participate in cardiac rehabilitation. And also, we would set it up for other populations, like possibly our COVID-19 long haulers. The improvements in wearable activity tracking makes this a very real possibility for our program, and many of these programs are already up and running around the country. This is the diagram and flow for this new proposal. I promise it's not really as complicated as it appears. The proposal will allow for easier access for patients because referrals could come from more sources than before, and will still allow for great customization and variety. This slide demonstrates on how we can meet our patients where they are and for what they need by increasing the number of options for care. Much of it is already in place. It allows for flexibility and customization for both the clinical exercise physiologist and the patient. In closing, my best advice is to continuously educate yourself on what you can do. Always question about what you can do more. Keep the patient centered to your efforts. Have patience and keep loving what you do.
Let's get right to the questions for our panelists. These are first on the list is Casey Brandenburg. Feel free to unmute and ask your question.
Thank you, Trent. So my question is actually to Matthew. I apologize that I was a little slow on the keyboard, so I wasn't able to ask you right after your presentation, but I just want to thank you. I was really interested in your presentation and I'm thankful for all the speakers and being able to hear from experienced experts. But so specifically, Matthew, I admired the fact that you brought up that your practice uses value-based programs and care to reduce the need for patient rehospitalization and readmission to rehab. And I think this is an extremely important goal for a lot of healthcare just facilities to have, is sort of helping the patient, reach full rehabilitation and gain independence from sort of like the hospitals and everything. So specifically, I'm curious to what your clinic has in place to ensure that the patients are getting this type of care. And additionally, is this value-based program common to most clinics? I'm fairly new to the exercise physiology field. Thank you.
Yeah, well, what I would say is I would hope that they have gone or are very soon going that way. And a couple things that I would say that I think are more unique to our centers. One is our phase 1 program is really robust, and we put a lot of effort into our phase 1 programming, which is the bedside, so our inpatient programming. My team starts working with patients in the cardiovascular ICU. So like I said in the presentation, within hours, we're interacting with those patients. If we're not walking, we're educating, and we're also educating families. And that's pretty much immediately where we start our care coordination, is if we identify patients who are going to have more comorbidities or maybe be more challenging cases, that's a time for us to talk to case managers here within the hospital to make sure that referrals are set up, maybe follow the patient a little closer in the weeks before they're even starting rehab. And we really just get a foot in the door. Two things and so that's not unique. A lot of places are doing phase 1 if they have the staffing for it. But two of the things that are unique for our centers is, one, we created the clinical coordinator position specifically to be someone who bridges the gap from treatment to those other siloed, what I would say are siloed professions. So diabetes educators, dietitians, folks that our patients need to interact with. So that's what that role is chiseled out to do. So that particular CEP plays a role of, yes, a clinician on the floor, but also integrating that care through more of a wellness model, making sure that we're facilitating the referrals through the treatment plan. And then the second thing that we do that we think is unique is we have a really good working relationship with our home health teams. They refer to us, we refer to them. we work very closely on a case management setup where we actually report out weekly on mutual patients who could be coming and going from our centers or back to the rehab setting. So I hope that answers your question. There's a lot to unpack there, and certainly welcome to email me and we could chat more about it if needed.
All right, thank you. Next on our question list is Isanya Bazan. Feel free to unmute and ask your question.
Hello. I had a question about cardiopulmonary exercise testing prior to surgery. If you guys think that it's beneficial as far as risk stratification.
Are you just talking about surgery in general, or are you talking about a specific type of surgery?
Mainly bariatric.
Yeah, I was going to jump in and think, it is really common for surgery, pre-surgery to have a stress test or a full CPX test as a way of just screening, right? These morbid obese clients are really high risk before surgery, and the surgeons really want to do their best to minimize complications. So I see it all the time that adults have to go through stress testing prior, not necessarily to eliminate them as a candidate, but to screen them for safety precautions prior to surgery. So, I mean, I do see it all the time with adults. You work at Children's, right? I got an inbox from you. So does your hospital do pediatric children bariatric surgeries?
Oh, no.
Okay.
Yeah, no.
No, no, I mean, it's kind of they have a list of blood work that needs to be done, and pulmonary testing that needs to be done just in order to be a candidate that, again, to minimize complications.
Right. Okay.
And just to add on to that, I mean, we all know that cardiorespiratory fitness or functional capacity is one of the single best predictors of morbidity and mortality. So regardless of whatever surgery you're talking about, I think the challenge we have a lot of times with our patient populations is if a patient needs to have the surgery, we're not going to not allow them to have cancer surgery, obviously. And with the bariatric population, a lot of them have orthopedic limitations, which can sometimes limit how effective a pulmonary stress test would be. I do know that there was a study at Beaumont Hospital that looked at using the new step and doing a stress test and having a cutoff for bariatric patients of, I think, about 17 mLs per kg permitted as being a predictor of adverse outcomes with surgery. We actually did an outcome measurement with patients who've gone through our bariatric program and have done like treadmill, just exercise training, and showed that if a patient is unable to do like 2 METs on a treadmill or 2.5 METs on a treadmill, which is like 2 miles an hour, that they have a greater risk of 30-day readmission in terms of ED visits. So I think there's a lot of opportunities for discussions with physicians and surgeons about the importance of not just looking at functional capacity, but doing prehab as far as exercising patients before a CABG, before lung cancer surgery. So that's another area of opportunity that I don't think we even mentioned today.
Right. No, and we do a lot of that even before they do the stress test is, 3 months of diet and exercise before they even begin, a serious protocol of, are you a candidate? Are we going to go through a battery of testing? So I think there's lots of rationales to why they do it. I think there are some studies out there that talk about, is it really needed? But, again, morbid obesity is just that high risk for mortality is working against them. So that's a good question.
Thank you.
All right. Thank you. Our next question will be coming from Catherine Gentile.
I had a question. Are you guys able to work with insurance for your patients as clinical exercise physiologist, or do you work like under an MD that is able to submit? Or I don't know if you could all just give your input on that.
We all just smile.
Oh, geez, who wants that one?
Well, I can start. If you're asking if we bill directly as CEPs for services, the answer is no. Cardiopulmonary rehab, which would include PADSET, pulmonary, cardiac, we bill under bundled charges. So we have CPT codes that are appropriate for specific diagnoses that have been approved by CMS. And I'll let others pick up from there.
Yeah, myself, I bill under a physician. So I'm, all of our services are under the guidance of a physician. We do have services that are out of pocket as well. So depending on how far out surgery, we have both diet and exercise, counseling that is out of pocket, and many patients will pay the out of pocket price. And that's just kind of in a nutshell how a lot of behavior modification programming goes is from the dietitians, the exercise physiologists, it's a series of stuff that needs to be done that costs money. That's part of the packaging for what has to happen to have a successful bariatric patient go through the program.
So I'll just chime in because this is a very hot button topic in terms of CEPA, and really when we talk about the CEP working outside of a hospital environment or outside of the physician environment, I am not aware of any CPT codes that an exercise physiologist can just bill for and get reimbursed. Similar to what Matt said, we bill under the same codes for cardiac rehab as most cardiac rehab facilities do, whether you're a nurse, whether you're a physical therapist or an exercise physiologist. So that doesn't really matter, although the scope of practice should, but that's a different discussion. I will say that for weight management, because I work in weight management also, I'm director of our program here, is we do have a specific CPT code that we use for exercise physiologists for doing preventive counseling. So that is something we use, but it's through our hospital, through the insurance, the company that we use that's has a relationship with our hospital. So there you go.
And I'm going to put a bow on this one, and I have now turned on my video to say hi for this, but we hope that in the not so distant future that will change. I am a member of an ACSM, American College of Sports Medicine National Task Force, and the purpose of this task force is to hopefully move the field of clinical exercise physiologists down the road to where they will be considered what a quote qualified healthcare professional, and along with that have more reimbursable services, whereas it is a CEP billing for their services as opposed through other mechanisms. And that could take up an entire another hour of discussion. So we're going to move on to the next question here, where the next person on the list is Adriana Rodriguez. Feel free to unmute and ask your question.
Okay, hello. So I had 3 questions for any one or more of you to include your input on. So is it relatively easy to switch among areas of CEP? I know a few of you mentioned initially working in cardiac rehab before moving on to other areas like bariatrics or oncology. My second question is, I recently talked to somebody who quit working in cardiac rehab because of the pressure of managing a large quantity of patients that ultimately compromised the quality of care that he was providing. So is this something that you all experienced? And then my third question was, I will come back to it when I remember it.
I can jump into your first. I'll jump into your first one. I think very seamless transition between chronic diseases. Once you've got some experience under your belt with one type of chronic disease, there's so much overlap from, I've done diabetes education, pulmonary, cardiac, bariatric, so I don't feel like it's not like, you're just going to pick a specialty and stick with it. So I do think an undergrad, at the undergrad or the graduate level, getting an internship in cardiac rehab is structured, They usually have some manpower. It's a great clinic to get some experience. And then if you end up Parkinson's or I've done students go to MS, working with MS patients. There's so much overlap in how we treat and care that I don't think you should do a silo kind of thinking of a career. So hopefully that helps. That answer. I don't know, Matt, you're currently in rehab. What's going on with the volume loads for that question?
Yeah, to that second question, I'll just be perfectly frank with everyone. Not all cardiac rehab facilities are fortunate enough to have the same resources. And those resources can be opportunities from their network within their hospital and their region, the resources of staffing, the resources of space, etc. So it would not come to a shock. It would not be shocking for me to hear that you might have a colleague or a friend who has left the field because they're feeling stressed. I know top-rate cardiopulmonary rehabs that run with 3 employees. I know some that run with 30. So it really just depends on the structure of the organization. And I think that I can speak for everybody on the panel today by saying this is why we are here as professionals, taking our time to advocate for CEPA, for CEPs, because the more traction we have in education that we can give and qualified professionals available, the better those services are going to be. And ultimately, we're going to serve our patients with that, and that will improve. So it's hard to speak individually to programs, but it's certainly possible. I would hope that programs are moving to the value-based care and they're working with one another within their hospital and their resources and improving that.
Thank you, Laura and Matthew. That did answer both of those questions. And I remember my third question, which was, as I was talking to this individual who quit cardiac rehab, which I actually have not had my own experience yet. I'm currently in a CEP master's program and finishing up my bachelor's in kinesiology. So I don't have any internship or clinical experience just yet. So he was talking about how going into cardiac rehab, a lot of people there are already set pretty much in their ways of the way they do things and don't really want to hear new ways or methods. So I was a little confused when talking to him about that because I thought that I guess continued education is a must when you're in the field. So an example he gave was he was delivering HIIT training with a patient and somebody told him in the clinic that had previously worked there before, like you're putting the patient in danger basically. And he had enough faith in himself that he went on with his HIIT training. And I'm learning in my bachelor's and master's that HIIT training is used in like heart failure patient population. So I guess how do you go about like battling the resistance, of people who have already worked and don't want to hear it basically?
That's a really interesting example that you brought up. And one thing that I was thinking about as Matt was giving his answer, and I thought it was a really good answer he gave there, is maybe you need to look at the leadership at that particular cardiac rehab facility, because to your point, you don't want to be running cardiac rehab like we did in the 1980s. And so for example, how necessary is it to get, exercise blood pressures on everyone in every set? And sometimes, there are unrealistic expectations and you lose, sight on the fact that you're here to help patients. And I definitely think that you need to, look for a program that's evidence-based. Is it run by a clinical exercise physiologist? You're probably gonna, like it better than, I hate to say, if it's run by a nurse or other, non-exercise physiologist. So that's something maybe to consider when you're looking at specific, internships or things like that. But yeah, you want to make sure you have a good sense of, the environment, and is it going to be a supportive environment that will allow you to, have an opinion and to go out and express that. Because yeah, that makes a big difference. If you feel like you have no voice in the workplace, you're not going to end up working there very long. So.
And I'll just jump in real quick as well. It's an excellent point. And to sort of jump back to the research aspect of things, Dennis mentioned that, 20, 30, 40 years ago, these programs looked markedly different than they do now. And that's because of the research has moved the needle. Data dissemination takes a long, long time. There are studies that show once findings come out, if it's, very favorable for a new type of training or sort of changing the paradigm from traditionally offered services, that's not going to happen overnight. So it definitely does take grounding any kind of proposals or any sort of ideas to leadership with the data. I think, especially if there's a university that's associated with a hospital. Here, we're lucky to have Northwestern University partnered with Northwestern Medicine. And so reaching out to clinicians there, reaching out to clinicians that you might be, familiar with their work at different sites that may be advocating for changing up to HIT training or to different kinds of training, and being able to sort of fuel those conversations, once again, based in the data, diving into the literature and really being confident in adverse event rates or how the outcomes might differ from one to the next. So I think it's important, once again, to be confident and able to dive into those conversations as well.
All right, thank you. Next question is Cindy Chu.
Hi, everyone. Thank you for all the helpful information. So I'm an undergraduate student right now, and I was just wondering if in this field, a master's degree is expected or typical as a prerequisite, or if just having the ACSM-CEP certification or just a bachelor's is enough.
That's a stellar question. I think I'm fit to talk to this because I do hiring like this all the time for cardiac and pulmonary rehab. So I'm going to give you a little bit of a mixed answer. The mixed portion of it is that it could largely depend on the region in which you live and the institution to where you are applying. So that being said, with our EP ladder here at my hospital, my EP1s are bachelor's prepared. I would certainly consider them for roles within cardiopulmonary rehab. My EP2s earn a little bit more money per year for their reimbursement, and they have a different job description and expectation. We certainly just don't pay people for a difference in their degrees if they're doing the same job. We pay them for the work. So with that being said, there are reimbursement opportunities for master's prepared individuals, but you can find careers in cardiopulmonary rehabs as a bachelor's prepared EP.
Yeah, and I would second that. I think as an undergrad, you will find positions that will state bachelor's and preferred ACSM certification. So if you're not ready to go to graduate school, explore what's out there before you make the commitment to pay tuition, because a lot of hospitals will help you depending on the size of the organization. Go back and go back to grad school. So I tell a lot of undergrad students, see what's out there with your undergrad before you make that commitment to spend more money on tuition, depending on where you live.
And I'll just add briefly that CEPA, every 5 years, we do a salary survey. And that's one of the questions we asked, does it make a difference if you have an ACSM certification or if you have a master's? And the answer to both of them is yes. So if you're looking at just from a financial standpoint, it does seem to help boost up that salary a little bit for both of those. So just something to consider.
Yeah, I can actually back that up a little bit. Very soon, in a few months, it's going to be published, is the latest updated salary survey that CEPA conducts every 5 years. And I can tell you right now that people with master's degree as practicing CEPs make more money than those who are bachelors. And if you add on a certification to that, that is also a benefit. So to kind of, for me to kind of finish off this answer is, yes, you can get jobs at the bachelor's level, but depending on the region, like Matt said, your resume might be there with master's level prepared or master's and certification or bachelor's and certification. So you might be competing for some of the same jobs that people with more academic preparation. It really depends on the region. And With that, I have one more question on the list. So Luis Sanchez, your question, please.
Yeah, thank you to all the speakers. So I don't want to, can everybody hear me just to be sure?
Yes.
Okay. So I don't want to make a too overly long question, but I guess I'll just give a quick background. So I have, a bachelor's in kinesiology, exercise science, and I spent a couple of years working at a rehabilitation clinic with the PTs, kind of working them through exercise programs with the patients, running the patients through exercises, ultrasound, e-stim, educating them, kind of with the helping the PTs with the patient load. And right now I work at a diabetic foot and ankle clinic. And this year I'm finishing my master's in physiology. But I guess maybe just a little bit of frustration, but just if I'll definitely take the advice of the CEPA. I didn't know about that before, so I'll definitely look into that too. But it's feeling like, I don't want to sound too callow, and it's probably the region I'm in, but it's feeling like with this career there's a lot of like gatekeeping or like gatekeepers, and I get it because I'm in New York, I'm from New York, and New Yorkers don't trust anyone ever. So I get, employers with that. And a little hesitancy, I get it with employers because, the whole thing of, since people don't stay in jobs long enough in a certain location, employers are less likely or more hesitant to, train up an entry-level person. But it's kind of feeling like there's a gatekeeping element to it. And I've had experience with EKG testing, setting it up on people, and almost all of the work I've done is in a clinical setting. But I kind of run into a wall a lot with my resume, sending it in, even looking for internship, even volunteering. But even volunteering, it gets harder the older you get because you have to you have to have a job. So I don't know if there's any other advice you guys have. And maybe it is probably my region. And hopefully now that I'm finishing my grad, program in it, it'll definitely bump it up. I could even look into a doctorate eventually. But if there's any advice you guys have, definitely let me know.
Well, like I had mentioned to the other person had a question, I do feel like there's some value in terms of looking at for places that have other clinical exercise physiologists, especially in leadership roles. Sounds like you were working under a PT, and interestingly, the salary survey showed that those tend to be the least paying as far as clinical exercise physiologists, and maybe we don't get the respect we should, in that realm. But that's kind of where I would look towards, at least initially, because at least if you're talking to other clinical exercise physiologist, they know your skill set and what you can bring to the table, whereas other allied health professions may not appreciate your background and knowledge.
Sorry, not to interrupt again. Super sorry, but I get that part. It just feels like there's kind of a catch-22 because there's a, in order to get experience, you need to have experience, or to have experience, you need to get it. And I didn't work directly in a cardiac rehab place, but I don't know.
So I'll give just a quick example that I'm going through this week. I have two roles that are available in my centers. One is a PRN, one is a full-time, both for EPs. I have over 45 applicants for each one of those positions. I have to fill those positions by teasing through basically resumes. So I have to look at 45 different applications for each of those. And I'll tell you, when I prioritize and I'm looking at it, I check education and I check the clinical experience. I get a lot of applications that have kind of the setting that you're describing with some PT, PTA background. I can decipher and look through some of that so long as I see some clinical experience. And I can just give you some insight. I'm not talking about me as an individual, but for the hiring process, a lot of my peers will think PT, and they'll think they're going to think musculoskeletal. They're going to see clinical cardiac rehab experience, even if it's an internship, and they're going to think it's going to be less training and onboarding. So as to the gatekeeping comment, I think employers are primarily looking at what their time investment is going to be to bring someone in, because they're probably trying to hire someone quickly that they can bring in that they think will be as adept as possible in the shortest amount of time. I know that that poses problems, especially based on your background and trying to get that additional experience, but it is worth your time, even if you have some observation, internship. And the other thing you can do is send me your resume. I'm happy to critique and give you some pointers. I'll tell you exactly what I'm looking at.
I think that's great feedback, Matt. I think so many students, we're looking for skills, right? So a lot of times we list where you've been under like the title, whatever, cardiac, physical therapy, instead of having skills that you can do. And I think a lot of times that will help your resume stand out when they see all of the skills that translate to a rehab setting. You know, goal setting, blood pressure monitoring. So I think that's great, Matt, you offered to help, but I think a lot of resumes I look at just don't show skills, and they state, I did 80 hours at this clinic. And it's like, well, what'd you do at the clinic? So that might help you, because I would agree gatekeeping is literally what is on the resume, and do we think you're a good fit?
And I'll add an additional point there. I mean, Matt brings up a good point in terms of a saturated application pool for various openings. That's certainly true across the board. And I think one thing that I found to be super helpful, and I was always taught to me in sort of a mentorship type of way, is try to network as much as you can. Try to make your intentions known as broadly as you can, whether it's emailing an individual at a local institution, asking for an informational interview, informal, try to get them associated with your name, try to send them your resume, as Matt mentioned, sort of extending your personal network, whether it's at conferences or a bit less formally with informational interviews of institutions or organizations you might consider appealing to work at, learning more about those things. The more hiring personnel that can, be aware that you're searching is only going to be helpful. Things like LinkedIn, those will help you out as well.
All right. Well, thank you all very much for being here. This was really a great presentation. Got a lot of good information from our experts, great questions from our students. Thank you so much. Again, like I said, if you wish to refer back to this webinar, I will get this posted up on the Continuing Education YouTube channel, which I did link earlier in the chat. It will include that additional informational talk from Mark Patterson on peripheral arterial disease. And if you have further questions, I know some of our panelists have put their emails in the chat, but you can also email those questions to Continuing Education, which again, I put it in the chat. And before I end the meeting here, I'll do it one more time. The email address for the Continuing Education, and you can send your questions there and I can make sure they get to our experts. Thank you again to our speakers. Thank you to our attendees. Hope you enjoyed it, and hope you have a good rest of your evening. Don't leave quite yet if you want that email. I'll be typing it out here in a second.